All right, so this is going to be my video on clinical written paperwork grading. And so again, if you watched the clinical performance video earlier, this is the other component to what gets graded every week for our student clinical paperwork. So this is written paperwork. Again, you'll go find your specific module as the instructor with your name on it in your course, and you're going to go to that week's clinical written assignment. All right, and so when you click on that particular written assignment, it's going to populate you in here to the assignment drop box, which is where the students actually submit their material. And again, inside the assignment box, it's going to tell the student every week you're going to submit a care plan for a grade. These assignments are due 3 days after your clinical rotation. Tells them specifically what day to turn it in, depending on what day they completed their rotation. For hospital clinical, please complete the following form, which is the clinical judgment care plan form. And I'll show you what that looks like in the Dropbox here in just a second. They need to submit their paperwork if they're at the prison. If our nursing 3 students are at the prison, they won't submit their paperwork here. It'll go to a different Dropbox. So just keep that in mind. If they're missing something for the week and they're gone for the prison, please don't mark them with a 0. Just mark them down as an excused. So the rubric is attached to this Dropbox, just like the clinical performance, and I'll show you how to grade based on what the student turned in against the rubric. So same thing, anytime you go to grade a student's paper, you're going to hit speed grader. It's going to populate you over to the students in your group. I've already hit it just so I can be on the test student. So when you hit your student grading, what you're going to see is what the student turned in. And so this is actually an old submitted plan of care from a student in the past. I've obviously taken their name off of it, and we want to make sure we don't have any like student or patient identifiers on here. But you'll see at the top, okay, this is our clinical care plan. They're supposed to put the date of their rotation, the week of their rotation, filling out like patient information in here, okay, that is pertinent, all right. So again, no patient identifiers. We never want to violate any kind of HIPAA or anything like that. But they are supposed to put like the admission date. Are they a full code? What's their height and weight? And then any major drug allergies. That all goes at the very top, okay? And so then really from there, what we start doing is we actually start grading. And so I'll make my screen a little bit smaller so we can kind of see the criteria. And so every section of the care plan has its own grading criteria. So you'll notice that they correlate with the top of the header on the care plan. So noticing, assessment, and recognizing cues is this whole section right here. And so this particular student, it looks like they have a patient that was admitted for CHF exacerbation. Their current medical diagnosis is acute CHF, exacerbation of CHF. She gives the pertinent history to this patient, okay? And then she also gives a history of present illness. So when they arrived, what happened to them, why they're in the predicament that they're in. So she gives a good, nice clinical picture of their present history and kind of walks them through that current stay. And then she puts a little bit in there about personal and social history, patient specific. And then on this particular section, for whatever reason, she did leave off the pathophysiology of the current diagnosis. I'm not really sure why that is, but that would be something that I would make sure that I would probably take at least a half a point off for, or make sure that she knows that she's supposed to be filling that out with a citation. So as I'm grading through this, right, and I'm looking at my criteria, the student identifies all cues, including their specific, significant subjective data, which includes all of these things up here. So their history of the problem, personal, social history, and then it goes on to talk about the objective stuff, which we'll talk about in a second. But while I'm stuck on this piece right here, I'm going to make a nice comment over here in my comment box and say, and this is how I grade as I go down, I'm just going to say, it appears that you left off the pathophysiology. And I like to make notes about what they missed so they know why they're losing points. And so that one I would probably put up I'll kind of show you what that looks like as we continue. This is the biggest section of this paperwork, and so there's a lot of pieces to it, but the next section included is going to be like the objective data, so vital signs, lab results, okay? And we want to make sure that the student is gathering as much information on that patient as possible. Unless they're like an in and out ER really quick patient, they need to have more than one set of vitals on this patient, okay? Ideally 3, okay? And then lab wise too, unless the patient's like brand new, we want to see them, we want to see some labs, and we want to see some trends in their labs if possible, right? We want to see maybe a white blood cell count from, admission to the current time. So if they can do that, that's also excellent. The next aspect of what gets graded in this section is this part, so the diagnostic tests and anything that's really asking you under here. And so she actually did list her diagnostic tests underneath this section right here. So it looks like she listed everything that patient kind of had going on. And she did include the majority of the results of most of them, not all of them. So that might be something I mention, is just make sure to include all the results of your diagnostic tests if available. Okay. So that would be the next section that I would be grading on her. As I continue down, we're still under this section. This is new on our paperwork this year, so she doesn't have that. I'm not going to obviously, I wouldn't count her off, but if a student left it blank, I would obviously make that comment. But the idea is to kind of gather meds that the patient is taking so that later on in the paperwork you can identify like the priority medications, okay? So any meds that you see on that patient ideally should be at least listed here with the idea of how they're prescribed to the patient. So the name, the dose, the frequency, the route, if it's PRN, what's the reason, and then any active provider orders. You will identify 3 of the priority orders later in the paperwork. So we want to list our major provider orders up here, okay? We want to make sure that those are reflected there. And then really the last part of this top piece is the assessment. So we want to make sure that she did a really thorough assessment. So it looks like she filled out her level of consciousness. It looks like her neuro assessment is pretty good. It doesn't look like I see anything in there that she left off. I could get a pretty good picture of this patient just by looking at that. Cardio wise, so kind of too, I have to remind myself to go back and look at, okay, this patient came in for CHF exacerbation, so I obviously don't expect to see a normal cardio or respiratory assessment probably on this person, especially with an EF of 15%. So I'm kind of going through here, and it does look like she's kind of got some signs in the cardio section. So let's see, pulse rate was 70, looks like +1 pulse over here, so slightly altered pulse, very dry legs due to Lasix, and she kind of added that to her assessment here on her skin. Looks like, let's see, she did identify like patient had a regular rhythm, no edema. Let's see. I would be a little confused about this piece right here. So, and like because she put yes edema, but then she also put non-pitting edema. So maybe the patient just had slight edema. I would just like to kind of clarify that. And then, let's see. So as I'm continuing on down here, looks like our respiratory assessment actually kind of looks okay. Regular, unlabored, anterior, seems like she's diminished. Currently the patient looks like they're on room air. I would ask her to make sure like if she's filling out this stuff right here. So she did fill this out. So productive cough, which is probably expected with COPD exacerbation or CHF exacerbation. Right now they have IS prescribed. Looks like the patient's GI history or GI assessment is okay. So again, as you just move through grading, make sure that each section you can get a good clinical picture and it matches the patient's, like, obviously their information. So again, this patient's a CHF patient, and they have been in the hospital and have been treated, so I would be okay with this assessment. But if they're brand new CHF, I'm going to question, like, if you chart everything up in the respiratory section as within normal limits, right? And in the cardio section too. So just kind of keeping that in mind, whatever clinical picture they've painted needs to match, their assessment needs to match. She did put some additional notes down here at the bottom. So she says, while giving a CHG bath, she pulled away several times from some soft tissue necrosis. Let's see. So she's just kind of put some other, while assessing lung sounds, at any time she would take a deep breath. So I'm assuming this is supposed to say deep breath. She would be coughing and it was productive. Was admitted with edema, and when her legs swell up, it's difficult to walk. So, I know they've been treating this patient, and that's fine. I'm good with this clinical picture. Again, anything that they say, I want to make sure matches, so I would go back up here to integumentary. It looks like she's got natural skin color, warm, no surgical wounds. She did put that they're very dry, normal turgor, but somewhere in there, if possible, let's see, did she chart that there was a... So she did actually indicate that there was some soft tissue necrosis to the foot, which is great. That's what I would like to see. So I would say, maybe along the lines of, it looks like assessment, good, thorough assessment. And that's it for that section. So again, the only thing I really could pick on in that section for this student is it appears that they left off the pathophysiology, and so I might take like a half a point off just for today. We'll just say that, like, you can do that. You can also take a half a point. It doesn't have to be a whole point, so just keep that in mind, okay? I don't feel like she deserves to have a whole point taken off because she meets the majority of this criteria right here. If she really struggled through it, like missing several patient problems, like her clinical picture didn't match her assessment, she just left multiple places blank, I would definitely mark her down to a 2. And if they're missing large amounts of information, feel free to mark them down to a 1, okay? So moving on to the next section, we have interpreting, analysis, and analyzing cues. So this first section in here is asking the student to identify the clinically relevant findings from what's above. Okay, so from all that intake, all that assessment, all that stuff that they did, what's the most relevant parts of it? So what we're asking them to do is based on everything: history, vitals, labs, diagnostic results, okay? Can they identify what's the most important? So out of her history, which is this first section, and social history, what are the most applicable findings? Well, she listed several, okay? You really only have to list one major one, but she's listed that this patient obviously has a history of COPD and CHF. She's listed a lot of info in here, so I'd say that's pretty sufficient. The next question it asks is to identify vitals or trends that are significant to that patient. And so it looks like she kind of identified that her systolic blood pressure was low, her respiratory rate was slightly high. She identified that the O2 was within normal limits, so that's a nice thing to see. I would expect them to tell me, like, hey, if their O2 has been in the 80s the whole time, that's obviously very significant. I want them to list that here. Relevant labs to the current condition. So it looks like she has listed out the things she felt like were the most applicable to this patient. And so sometimes I have to go up and look at the labs that they listed. But she did list 3 kind of out of range labs. So her creatinine was a little elevated, albumin was a little low, and hemoglobin was a little low. And she put her reasoning for those labs being abnormal here. And sometimes it'll ask you, like, is there a trend on it? Is it increasing? Is it decreasing? Is it getting better? This one wasn't trended, but it does tell her, she did tell us what the nursing relevance was to that, which I'm okay with. So we just need to keep in mind, too, sometimes they don't have access to, like, weeks and weeks of labs. That's okay. Just keeping in mind, they're identifying the important pieces out of that lab information. Same thing here as we continue on with diagnostics. Out of that stuff above, it looks like she was able to identify that that patient's ejection fraction was like 20%, which is probably the priority, right? If you're looking at diagnostics. I would say, anything along the lines of like a chest x-ray that shows like complete lung consolidation or whatever. Anything that supported that clinical picture that showed the high priority of that patient having really significant heart failure. So she did a good job of picking that out of her head to toe. What we're asking is for 3 assessment findings that are relevant to the patient's condition and the most priority thing. So out of that, she knows that this patient's got CHF. What we're hoping she picks out of it is things like shortness of breath, diminished lung sounds, edema, crackles in the lungs, or things like that. So it looks like she did say that the patient has diminished breath sounds, something I probably wish she would have added, which she kind of did. The patient began to cough, so I'd say that's okay. She did note that the patient had some edema and skin necrosis on the toes, and then weakness. And so again, it looks like she did a pretty good job of identifying the assessment items that are priority to this person. The last thing we ask him in this section is if the patient's 65 and older, is there any specific assessment findings or labs or anything that it requires special consideration from the nurse. She put here that decreased kidney function is an increased risk, which is great. We know that from the elevated creatinine. Higher sensitivity to meds, skin fragility, receiving Lasix. She's at risk for skin breakdown. She does have a pleural effusion. So she's kind of picked out some things that are specific to that 65 and older population, which is really pertinent. So on this section, honestly, I would give her 3. She identified all of her patient-specific cues, vital signs, diagnostics, assessments, explained why they're relevant. So if she had done a less thorough job, I would probably knock her down to a 2, or if she was missing a few places. And again, if they're really struggling to identify the priority, like if their patient's got CHF and an EF of 15, but they're putting that their priority up here is, the fact that the patient's got poor skin turgor, like that's misidentifying the priority, and they need to understand how to reprioritize. So making sure that they're following along that clinical path. So the next one, section, again, we go section by section. Interpreting, analysis, and prioritizing hypotheses. So what we're asking from there, we're continuing to kind of narrow down the clinical picture. What are the 3 highest priority concerns based on all of the data in this section above? Okay, so out of all that stuff that she gathered, she says that the 3 things that she feels are the highest priority are the reduced ejection fraction, which I would agree with that, probably, okay. Fluid overload as seen in, so she's taking the data that she's gotten and she's giving the supportive factors to it. So what is a concern? What are your cues supporting the problem, and why does it require the nurse's attention? So reduced ejection fraction, severe heart failure, decreased cardiac output. A finding puts the patient at an increased risk for decompensation and cardiogenic shock, okay? The thing I would probably say about this top one is she needs to probably give some more, data that shows relevance to this, but she did a pretty good job. Fluid overload as seen in the effusion, edema, ascites. So she did a great job here of explaining why, what about the fluid overload do you see in this patient and why is it a problem? It indicates that there's worsening CHF, could cause impaired gas exchange. That's why it draws our attention, right? And then the elevated creatinine of 1.19 shows a decreased renal perfusion, and it's important to monitor because this may worsen with diuretics and ACE inhibitors. So that's kind of, again, same thing. She does do a really good job of bringing in the 3 biggest points. The other thing I could say would be arguable would be some necrosis on the skin that you could probably take into account here. If you wanted to, that would be fine. It's kind of one of those things when we teach students, how do you prioritize? It's what are the things that are going to really kill your patient the fastest? And so that's what we want to see them start to narrow things down to. The next section inside this is going to be from the orders that you identified. What are the 3 that are most important to managing these problems? Okay, so for the problems that she identified, she said that Lasix, which is great. She's talking about fluid overload up here. A fluid restriction of 1,800 mils is also great. Again, it goes along the lines of our fluid overload. And then telemetry monitoring, which is important for that reduced ejection fraction. Okay, so those are really good identification of provider orders. If they would have said something along the lines of like, bed rest, instead of identifying that, hey, there's probably some more pertinent orders there, then you obviously can reassess your grade here. And the last thing it asks in this section is identify complications that have not yet occurred, but that the patient is at risk of developing based on their current assessment findings. So it looks like she's put down here the patient's at risk for developing acute respiratory failure, as evidenced by their pleural effusion, diminished lung sounds, productive cough. Patients at risk for developing an acute kidney injury, as evidenced by a creatinine and decreased cardiac output, and the patients at risk for developing cardiogenic shock, as evidenced by ejection fraction. So those are all very appropriate. I feel like those are great. When you go over here to the grading section, what she's done, I think she's done a good job at. She accurately identifies the 3 specific priorities based on the history, vitals, labs, and diagnostics. She can identify 3 priority provider orders, and she's identified potential complications. The only thing I would say is making sure that she's got a good rationale next to it. So making sure that they are telling you why they think that this, like they can't just put the patients at risk for acute respiratory failure. Okay, why? These pieces are important to that in supporting that particular problem. Okay, so I would give her 3 points in that section. I think she did a good job. The next section we're going to grade, and as it continues to go down, and the more you grade of these, you'll notice what it's doing is it's just narrowing down that clinical picture to the highest priority problem. So of the complications identified above, what complication is the highest priority for the nurse to treat or recognize, and why does it have priority over the other 2? So she says, based on all of these problems here, her biggest priority is treating decreased cardiac output due to severe heart failure. Well, I would agree with that. The patient has an ejection fraction of 20%, okay? And it has priority because it affects perfusion to all organs. It leads to fluid overload, respiratory impairment, renal impairment, and then cardiogenic shock if not managed, right? So based on that, what we're asking him to do are, what are 5 interventions that you would do to fix this, or to prevent it, or detect it, or respond to it, okay? So based on my priority problem, what she says she's going to do is she's going to monitor vitals and telemetry. She's going to give the prescribed medications. She's going to assess fluid status. She's going to position the patient in high Fowler's, and she's going to monitor their labs, specifically potassium and creatinine. Okay, those are great interventions. Okay, the one thing I would say is what I want to see here are the prioritization of things like your ABCs. If that patient is struggling with any part of their airway, their breathing, or their circulation, this is where that needs to be reflected. So she does a pretty good job here. I would say that, and again, making sure that they understand, like, she does a good job over here of like saying, like, making sure improving I would do meds because it helps improve my breathing. I know the patient's not in any respiratory compromise at the current moment, and she does a good job of prioritizing circulation too. So monitoring their vitals, monitoring their telemetry status, those are all very priority and important things to do on a patient like this. So as long as I can recognize that, she does a great job. What it's asking is accurately identifying the specific priority, providing the appropriate interventions for that priority, and then giving an explanation of each of their clinical relevance. It doesn't say in here to provide a citation, so I haven't been counting off if they don't. So just keep that in mind because I think that may have gotten missed. But so that's something that, in general though, what we're asking is, do your interventions match the priority problem that you stated? And so again, if she's got her priority problem is an EF of 20, but her nursing intervention is, oh, I'm gonna, like Q2 turn my patient, or I mean, again, those are important, but what we're asking is for them to really identify the interventions that go along with the priority issue. So making sure that they identify that, which she did a really good job of. The other section in here is this: what interprofessional team members have expertise. So we just want to see that they can identify like the people that help, right? So respiratory with respiratory status, dietitians, pharmacy, wound care, okay? Those are things we want to see listed here. The next step is going to be interpreting, implementing, and action. So from the interventions, what's your priority intervention? What makes them the highest priority? She says vital scintilometry, diuretics, assessing lung sounds, which I would agree with that. Again, we're trying to help them identify that, hey, these are the interventions you listed. What's your biggest priority? We don't want to see skin care or wound care prioritized over an immediate need to provide oxygen, right? So we're trying to get them to understand that oxygen comes first, skincare comes later, things like that. So she does a good job here of kind of prioritizing that. What patient care activities could be delegated, and what assessment remains the responsibility of the RN. So there's things up there that we want to make sure that, that they are identifying. So if there's daily weights, eyes and O's, bed bathing, we want to make sure that they're identifying what can be delegated and what should not be. So we never want to see meds being delegated. We never want to see assessment stuff being delegated. Those kind of things, making sure they understand that they are responsible for the initial assessment, for med administration, for reassessment. So the next section inside here too is what is the highest priority patient or family education needed for this patient. She identified quite a bit, it looks like, on education. So educating the family on how do you manage heart failure, right? Adhering to your medications, why they're on a fluid restriction. Again, this piece needs to match the clinical picture, right? We need to make sure that what they're educating them on matches everything else up here that they've identified as the priority problem. The next part of this section is their med list. So from the meds that they kind of gathered, what are your priority meds really, and what are we using them for? So she's listed enoxaparin, furosemide, lisinopril, metoprolol, and spironolactone. What kind of class are they? This basically just needs to be completed, and we need to see that they're following the trend of what it's being used for the patient's condition. So what's its mechanism of action, right? Why, what's the indication for it? And so she's got several in here that she shows they're being used to treat for CHF and or reduce the complications associated with CHF. So that's great. The frequency, any major side effects, any major nursing considerations, what kind of evaluation did you see if you gave it, right? And then they need to include a reference, which that'd be one thing I'd make sure that she does do in the next one, and that's something I would comment on, and I would say make sure you cite your meds in your med list, okay? So that's something really important. We can't obviously know this information most of the time off the top of our head. It would be crazy if we did. So they have plenty of resources. Nursing Central app is one that our students use a lot. So that would be something I would make sure that she knows to do the next time, and I'd probably maybe take off like a half point or something this time. So the last part of this grading section is going to be from the meds above that you listed, what's your priority, okay? She puts lisinopril and metoprolol. I'm going to look back up here and honestly probably say Lasix is her priority. So I know that's kind of hard sometimes with where they're at in the program and understanding what those meds do and what they're for clinically. So I would say, maybe a comment on that and say, I think furosemide takes priority over your other meds in the management of CHF. And I would just make that comment on there. if she's 65 and older, what med safety considerations should be noted for that type of patient. So increased sensitivity, we know that older adults often have increased sensitivity, renal function, electrolytes, fall risks, especially if she is taking furosemide and other medications that lower their blood pressure. So those are things that we want to see pointed out, and that's really that she does a great job. So if I'm looking at my criteria over here on my grading, it looks like she did the majority of it. Appropriately determines what actions should be taken. Her interventions are prioritized appropriately. Identifying the necessary patient and family education, and then completing the med table thoroughly. She does a pretty good job. Again, the only thing I could nitpick her on would be, again, and I'm not going to take a whole point off, is just that understanding the priority of your meds, right, and citation. If she missed a lot of meds, or really just missed the point of how to prioritize this stuff, or really missed the big intervention, you can always reduce their points, right? If they're really not getting the clinical picture, you can take them down to a 1. The next section is going to be on reflecting evaluation and evaluating outcomes. So reviewing the desired outcome for your highest priority complication. Was your outcome met, right? We kind of have to know what was your desired outcome for your priority complication. So it looks like, if you go back up and you look at what her priority complication was, she's saying it's a ejection fraction of 20 to 25%. So I'm looking to see if, what she's saying in her desired outcome was for her heart failure to kind of improve, or maybe to show less signs and symptoms of poor cardiac output. So she does say her edema was improved. She was more comfortable. Her stomach was still showing ascites. She had some swelling in her ankles. Ejection fraction was very reduced. So she did identify this has some cardiac dysfunction, and perfusion issues have not been resolved, right? Her assessment findings, which assessment findings indicate that your interventions were effective. So again, if we're doing an intervention, we're always reassessing to see if it's working. She did have an improved respiratory status. She had reduced edema, which was indicating that her medications were effective. She was slightly upset because it was important to use therapeutic communication. So those are some things I think she identified pretty well. What were their response to the interventions? Should the plan be continued? Based on the response to the intervention, should it be continued? So short-term outcomes allowed for symptom relief, removing the fluid. Long-term things like cardiac dysfunction were not completely fixed. And so that's a good thing to identify. What patient cues should the nurse reassess? We're always looking for them to tell us, reassess vital signs, reassess those big picture items that are going to trend whether our patient is improving or declining quickly. So she says vital signs are respiratory assessment, daily weights, I's and O's, pedal pulses, skin color, labs. So she does a really good job at pinpointing the big factors that obviously we can consistently reassess in this patient to see how they're doing. And so that is the majority of that. The last part of the section that is still here is going to be filling out their reflection based on their SLOs. So what did she learn? And we want this to be like 2 to 3 sentences long. This doesn't need to be like a short, like I did patient care, okay? So ideally, what did you learn today? Well, I learned through a bed bath how to, therapeutically communicate. I was able to do... I was able to learn how to interact with family members. We really want to see what they actually learned. So I asked them 4 different questions about their student learning objectives, and we really just want them to reflect on what they actually did to kind of gather, to learn from the reflection that day. And so for her reflection, 3 points would be identifies and explains the outcomes and the response. She did determine if the outcome was achieved. She was able to reflect on the clinical day's experience and the correlation to the SLOs. If she really just put like one word answers or like really short answers here, you can always reduce it to a point. And then if they're just really struggling to either one, they just don't answer, or two, they're just really struggling to understand like what they should be reassessing, or if their outcomes were met, we also can, again, you didn't identify any expected outcomes or achievement of those outcomes, you didn't complete your reflection, we can always take them down to a 1. She did great, so I would give her a 3. The last thing is grammar, spelling, and clarity throughout. Can we read it? Can we see that there's very few errors in grammar, mechanics, spelling? If there's citations required, did they put them on there, and did they put them in an appropriate citation format? So those are things we want to make sure are there. The only thing I would say on her is like, I would, again, maybe there's some places she could have added some citations, even if it's just at the bottom, that I would probably pick out for her. So I would just say, make sure you're including references and citations in your work. So I would put that there. Again, take off a half a point for something that minor. And then once I've hit all of these points, I'm going to hit submit assessment. And I'm going to go back up to the top, and I'm going to see that my total assessment totals 19.5 points out of 21. That's what I'm going to type in as the grade for this student. I'm going to hit, it's going to save it for that student. If it ever doesn't, just hit submit at the bottom, or hit submit at the bottom, submit assessment, and it'll save your grade. And so that's really the gist of clinical grading. I know it's very long and tedious, especially the first couple of times you do it. But as you look through this, you'll kind of be able to pick out more easily what the student is supposed to be highlighting and hitting, if they're doing what they're supposed to, if they're getting the information and getting the clinical picture and able to formulate a good plan of care. So that would be the end of that, and let us know if you have any questions.